So much of the healthcare system administratively is built on repetitive functions. If I could automate that, take the employees currently doing that and have them do higher order work, taking care of patients, I think we'll get a lot of efficiency into the system.
I'm Chris Malone, and I'll be your host for today's discussion. Thank you for joining us. Before we begin, I'd like to welcome members of the Planetree community, our partners in this program. Planetree is a global, not-for-profit organization dedicated to humanizing healthcare for everyone through excellence in person-centered care. I'm very pleased to welcome Mandy Kilmartin, Director of Global Partnerships for Planetree. Hi, Mandy. What can you tell us about our guest today?
Hi, Chris. Thanks for that. And welcome, everyone, to our May episode of Humanizing Healthcare. It gives me great pleasure today to be able to introduce our very special guest, Mr. Kevin Mahoney. Kevin is the CEO of the University of Pennsylvania Health System, leading operations across 6 hospitals, 11 multi-specialty centers, and hundreds of outpatient facilities in Pennsylvania, Delaware, and New Jersey. Kevin's held various leadership posts at Penn Medicine for nearly 3 decades. Before his appointment as CEO in July of 2019, he served as Executive Vice President and Chief Administrative Officer for the University of Pennsylvania Health System, and as Executive Vice Dean at the Perelman School of Medicine. Kevin is a strong advocate for healthcare access and equity. His perspectives on access to quality care, health equity, and social justice have been published in the New England Journal of Medicine, the Journal of the American Medical Association, and the Philadelphia Inquirer. In 2022, he was named one of the 100 most influential people in healthcare by Modern Healthcare. We're pleased to have Kevin here with us today and look forward to hearing the inevitable inspiration and wisdom he will impart. So without further ado, Chris, I'll hand it back over to you.
Kevin, welcome to the program.
Thank you, Chris. Mandy, I appreciate the time, and I'm looking forward to our conversation.
To get us started, can you share a story about how you began a career in healthcare? Where did it all start for you?
I went to a small state school out in Lancaster County called Millersville State College, and while I was out there, I made the dean's list. Unfortunately, it was the dean telling me 1.98 is not a sustainable grade point average, and you have to go home. So I came home. My dad said, "You're a knucklehead." I said, "Well, we've established that. Go get a job." So I went to work for a landscaper. And out to the west of Philadelphia, it was still all cornfields and trees and pheasants, and it was small town America. And I was hired by a gentleman by the name of Bill Rouse to cut down this cornfield in the middle of the summer. And I asked him why, and he said, "Because I'm going to put offices out here." And I said, "Mr. Rouse, people sleep in the suburbs, they work downtown. They take the train into the city, they drive the expressway, they sleep in the suburbs." He said, "Is that a rule, regulation, zoning? Like, why?" And I said, "That's just the way it always has been." And he put down his cigarette and he said, "Kevin, never do things the way they've always been. Do them the way you envision them." So that, for a young 19-year-old, that imprinted on my brain for reasons that I don't know why, but it did. I then started cutting the cornfield for him, and I fell off the tractor, under the tractor, and the tractor ran over me.
Oh, my goodness.
Hospital on a ventilator, priest giving me last rites, my mom crying, and I had no idea how sick I was. And remarkably, I enjoyed every minute of being in that hospital. And it was a place, I said, "I can't believe everybody wants me to get better." And for a self-centered teenage male, to have everybody trying to take care of you, like at first I thought, well, of course they are. But then I started to think, why are they doing this? Why do they leave their families and come in and take care of me? And it so inspired me that I wanted to work in the hospital. But the year wasn't done yet. I went back to Millersville that fall. I had to stay out of school. I went back to Millersville to meet the same knuckleheads that got me in trouble the first time. So that's where we ended up in a bar. And I walked into the bar on November 10th, 1978. And I immediately fell in love. And I said, "We should get married." And my wife said, "I don't think so." But 40 years later, we're still married. And Pam is my yin and yang. I'm Irish and wired. She's calm, cool, and collected. I bring problems home from work, and she says, "That sounds like your problem, not your worker's problem." She's been my confidant, my best friend. So I got into healthcare because it's events that happened quickly in that summer.
Wow, that's a remarkable story. And how do you expect your efforts to improve patient access and health equity? How do you think those are going to impact patients and care providers?
Sure. I think it's critical that right now, healthcare is such a blunt instrument. We think with this immune profile that'll include your genetic makeup, you have to get your screening colonoscopy at age 30 because of your family history. You know what? You don't need to get one. And then all of a sudden, that targeted access, I think, okay, if you said to me, give everybody in your service area, 27 counties, free Uber rides, I'd be like, I can't afford it. But if it was two people in West Philadelphia that need, because we know they need to get in, I can do that.
That makes a great deal of sense. And I think to your point earlier about greater efficiency, while not impacting care, can possibly be through that path of personalization, right? To the extent that we have kind of a one size fits all approach or process or what have you, that can add cost. Whereas if we've got the ability to personalize, on genetics, for instance, as you described, that can really make things much more efficient while enhancing quality of care. Now, you've also mentioned that Penn Medicine is becoming a more provider-friendly institution. How do you expect that to impact kind of clinical outcomes and patient experiences when your care teams are perhaps feeling more empowered?
So I think the healthcare system has become absorbed with hurdles to prevent care. So pre-authorization, denial of care, the amount of time doctors are spending and nurses documenting, it's off the charts. I'm a contributor. Every insurance company is a contributor. We just keep putting more and more onto the physician. So again, are there ways that we put in a program for pre-authorization of x-rays? We had 51 people doing nothing but pre-authorizing x-rays, and less than 1% got turned down.
Mm-hmm.
So can I redeploy those 51 people to help people navigate the system, which would make access better, to help patients as opposed to just putting in regulations? What we put in place was an algorithm that if the doctors follow, they don't have to go through the pre-authorization. But it's freeing up time away from the unimportant task to the important task. When you're not stressed, your time with the doctor is going to be better. When the doctor is not stressed, when the doctor has more time to spend with you, we're going to get more accurate histories. We're going to be able to explain things. The nursing staff, if they're not constantly updating records, so physician-friendly, provider-friendly, nurse-friendly, it's our overarching theme of we need to make medicine easier and simpler for the provider. If we do that, the outcomes will be better because you might pick up that stray thing as opposed to typing away on the computer. That odd thing that the patient said, you might hear it and delve into it and find out something interesting in the history. So I admire the 48,000 people that work at Penn Medicine. I went back to my own personal experience. I think they are angels on earth that are doing incredible work to improve our lives, and they need our support. So being provider friendly, it's a term we came up with, but it's mostly respecting healthcare workers and let them work at the top of their license as opposed to doing so much mundane administrative work.
That sounds great. And can that all fit into this notion of cost containment as well? I know you mentioned efficiency before. And, often, the perception is that, efficiency efforts are about cutting corners or increasing volumes or making things more transactional. And, do you think there's a balance there that we can find the efficiency without it turning into an impersonal transactional connection?
Yeah, no, clearly, there's a lot of talk about artificial intelligence, it's going to replace doctors. Like, it's not. But one thing AI is really good at is replacing repetitive functions. And so much of the healthcare system administratively is built on repetitive functions. So if I could automate that, take the employees currently doing that and have them do higher order work, taking care of patients, I think we'll get a lot of efficiency into the system.
Yeah. And, perhaps what that will do is contribute to stronger relationships between patients and care providers. They get to spend more time together. Is that something you think is important? And if so, how do healthcare organizations foster those relationships while they're kind of managing efficiency and cost?
Yeah, no, we know that longitudinal care with the care team is the best care you can provide as opposed to episodic care. I grew up, Dr. Batafrano took care of me and my 8 brothers and sisters, and it was, he knew all of us inside and out because we only went to Dr. Batafrano. Those days are behind us, I understand, but we don't have to go to the extreme now where you see a new person every time. So under that provider-friendly system, if we could free up a little extra time so that the doctor could follow you on a longitudinal basis, I think it'll make all the difference in the world. A lot of inpatient care now, a team will do a week at a time because 2 weeks at a time is just, you'd be burnt out. It's too hard.
Wow.
So if we can make it easier and maybe they add a couple extra days to the time that they're in the hospital, there'll be more continuity of care that'll lead to better outcomes.
Very interesting. So you also have some very interesting initiatives moving to kind of lower intensity settings, such as telemedicine and home healthcare. How do you see this fitting in to that relationship and that experience when kind of the experience is leaving the four walls of the hospital or the doctor's office?
Yeah. It's a great question and it's a challenge because when people think of healthcare, they think of hospitals. We're built as a hospital-centric delivery system. At Penn Medicine, we talk a lot about 4 sites of delivery, the hospital for sure, but we now get 60% of our revenue from the outpatient side, and it's growing quickly. So, I have 135,000 inpatient admissions. I have over 7 million outpatient visits. That's where the future is. We have almost 1 million a year of home care visits, but remarkably, Chris, within that home care department, we also do home infusion. 50% of the chemotherapy and medical infusions done at Penn are done in the home.
Wow.
So imagine you don't have to get in your car. You don't have to drive down the expressway. You don't have to go to the hospital. You can sit at home with your puppy. You can have your favorite show on the TV. You can sit in your own comfortable chair as opposed to, the bricks and mortar of our healthcare system. And then you get to telemedicine. It will continue to change how we deliver care. So you're in Florida, California, across the globe, and you'll be able to access Penn Medicine care from your phone. Like, it's still nascent. We're making great progress and moving forward. It also provides the opportunity, telemedicine does, all of the critical care beds in Penn Medicine and all of our hospitals, 400 or 500 critical care, are all monitored centrally by a doctor or nurse practitioner, and we're pulling all the data from the ICU, the blood pressure, the respiration, the pulse oximetry, all of that's getting pulled in. So it's an early warning system of, you better check on the patient in bed 15 because, there's something. So we have algorithms that go through that. You better check on the patient in bed 20 because they're trying to get out of bed and they're not supposed to be. And it's belts and suspenders for the nurses that are on the unit. But begin to imagine if we could expand that to every rural hospital in Pennsylvania,
Right.
where there's a shortage of providers. So I'm bullish on deconstructing healthcare away from the bricks and mortar hospitals into patients' home onto their iPhone. We need the rest of the system to adapt to that. We get paid more for an inpatient than we do at home, but everyone keeps saying treat people in a less costly setting. We have to provide some incentive to everyone to do that.
Yeah, I think that makes perfect sense. And I think the degree to which telemedicine and outpatient care can be a complement to your in-person interactions rather than a complete substitute for them, right? That can improve access, keep greater continuity, keep people engaged, whereas that access issue right now is part of the barrier of continuing care.
I'm not suggesting hospitals are going away. We're always going to have hospitals. It's just what you said. It's all complementary. And I think one of the things that we try to build at Penn that's unique is we own and control all the sites of delivery. So as the patient moves down that chain, I'm not resisting it because, go outpatient, we still get paid. Go in, back in the inpatient, we get paid. Go home, we get paid. Go virtual, we get paid. Some places that haven't been able to build all 4 sites, you resist moving to that next stage because you don't get paid.
Yeah, makes sense. Now, during your tenure, Penn Medicine has also launched a partnership with the Wharton School at Penn I'm wondering what kinds of opportunities do you see for collaborations between health systems and startups? And are there any success stories you can share that might kind of inform us on this?
This is one of my favorite initiatives in my nearly 30 years at Penn. We started a venture fund for life sciences, and it's done phenomenally well. We were then talking to our colleagues over at the Wharton School. They have a class on social impact investing. And I found that intriguing. And I said, like, what do you invest in? Well, we're looking for companies that do well by doing good. And I said, could we focus on Philadelphia-based companies that are going to help us improve the social determinants of health? The students at Wharton vet the companies. They provide coaching, mentoring, business plan development, and then the health system funds it. And I think we funded maybe nine or 10 companies so far. They're not dramatic in terms of they're going to be on Wall Street, but they're dramatic in terms of they're improving people's lives. So we have a great company coming through, Caregiver, Caybera, Caregiver Care, which is eliminating maternal morbidity and mortality in females of color. What the patient gets is a nurse navigator, a midwife, or a doula that helps them through the system. When Pam was pregnant, we called my mom. My mom had eight kids. Like, she was pretty much an expert on having kids, and she could answer it. Today's world, where everybody's running around, some of these young moms don't have that care provider. So assigning them a care provider, navigator, I think is going to lead to dramatically better outcomes, because we're taking care of that's just one example of the type of companies we invest in.
Very interesting. And it sounds like Wharton is kind of helping you with the due diligence on some of this to kind of do the screening. Is that about right?
It is. We are fiscally disciplined. So when we started the Life Sciences Fund, the president of the university said, you need a co-investor on every one. And I said, why? And they said, well, if you're any good at investing, you wouldn't be a hospital administrator, you'd be on Wall Street. Same thing with having the due diligence of the Wharton students go through. They get credit in their class for the social impact advising that they're giving these companies. The product's better. They have vetted it. I don't fall in love with, a sales pitch, because they're doing the due diligence. So the checks and balances within the Penn system are powerful.
Excellent. A few other things we've seen online is that Penn Medicine has opened some new facilities, like the Cancer Center at Princeton University, Hospital of University of Pennsylvania Pavilion. I'm wondering where kind of patient experience fits into these new facilities, and if there are any new innovations kind of being built into those.
Yeah, no, it's a great question. I'll use the pavilion, which you might be able to see over my shoulder. This is our 1.5 million square foot hospital that we opened in October of 2020, in the middle of the COVID pandemic. But we built a replica of half of one of the floors, 30,000 square feet, out of styrofoam. And then we went to the School of Medicine, where we have standardized patient actors, and they get paid to come in and role play being a patient in our facility. And we put 14 GoPro cameras up, and we filmed everything. So patients in the bed, they're told they have left-sided weakness, and we say, get out of the bed and go to the bathroom. And it helped us where to locate the bathroom. What would be between the patient and the bathroom? Well, the IV pole, the different. So how do we clear all that out so the patient has a clear way in? What was fascinating is what the architect thought and what we thought were often revealed through the GoPro film to not be accurate. And the building has some curves to it. When they were delivering food, they would slow down around the curve, and they asked why. The architect's answer was, the hallway is still 10 feet. The delivery person said, I can't see around the corner. But we picked it up on the camera. So that's one. The second is we have patient family advisory councils at all of our facilities, including home care, but each of the hospitals. And, they're invited in to help us design, redesign, and tweak going forward. we're doing one of our inpatient towers, and patient family, I don't care what you do, make sure that I can charge my phone, because my cord's only this long and the extension, the outlet is far behind me. And, those are things that an architect wouldn't think about. So we try to make sure we get the voice of the patient into all of our design.
Well, it sounds like a great example of what our folks at Planetree would call person-centered design, right? Whether that person happens to be a patient or a staff member or a clinician or what have you, we've got to make sure that we're building those spaces in a way that enable the experience that we want.
And the other thing about the patient-centric design is we generally design healthcare facilities through user groups. And the user groups are generally nurses and techs and physicians. And we end up designing it would be best for us, not necessarily best for the patient. So trying to flip that. My dad was in and out of the hospital a lot, and I tried to use that experience to convey what I wanted, as opposed to being the CEO saying this is what, but as a visitor with my dad, this is what I experienced. So I think it's a really good point, Chris.
Great. Now let's take a few questions from our listeners. The brand image of the healthcare industry in the US is one of profit at all costs. How can we stop or change that?
Yeah. So I talk about the margin a lot. Thanks for the question. It's critical. The Wall Street Journal has an article on it today. It is written about often that medicine's become corporatized and the dollar matters not. At Penn Medicine, the dollar matters. But it matters because 60% of what we make, we put into research. And I think that differentiates us. So I try to make sure that we go through the golden circles, what, why, how, what, and why are we here? We were founded 265 years ago to create and disseminate knowledge. Unfortunately, they has morphed into, as our listener said, it's morphed into make more money. I want to make sure people understand we're making money to fund research. We're not making money to just for the sake of making money. The other part of the efficiency, I want more of that money we're making to go into employee salaries, to go into physician salaries. And the emphasis isn't on making money. The emphasis is on the provider friendly system. But we have a challenge. Private equity is a challenge that we need to wrestle with as a country. Systems getting bigger and bigger is a challenge that we have to wrestle with. Hospitals closing in the poorest parts of the country, whether it be rural or inner city. So the listener's question is spot on. I'm doing my best for my slice of the pie to make sure that we stick to our nonprofit roots.
Excellent. Penn Medicine is world-renowned as cutting edge for medicine, and your new DNF profile is going to help personalize and target clinical care. How can we also personalize the human side of medicine to make patients feel individualized, feeling seen, feeling heard, and valued?
Yeah. So again, a wonderful question. We work on it every day. At every board meeting of every hospital, we go through the dashboard of patient experience. We train patient experience. One of the great events we have is Patient Experience Week. It is as important. A credit to the Cleveland Clinic and Toby Cosgrove. They developed a video that we play often. I even give them credit, but it's on empathy. It's that feeling that I had when I was in the hospital as a teenager, that I was the center of the universe, not everybody else. And we need to keep pushing to get back to that, despite the rapid pace, despite, COVID, it started as a unifier, it turned into a divider. And, a lot of arguments with patients and patients' family over masking and things like that. We have to figure out how to put that behind us and focus on improving that patient experience. Remember the Staples commercial where you could hit the easy button?
Right.
We would like the delivery of care for the patient to be like hitting the easy button. And if they do that, their experience is going to be better. So we just finished a study on circadian rhythms in the ICU. Rather than waking people up, can we let them sleep? And the answer was, yeah, outcomes are better when you do that. So all the lights in our new pavilion are controlled by the patient. So it's not, the care team walks in and turns the light and disrupts sleep. So I think a lot of what we need to reorder is patient centricity, design and experience, provider friendly, provider easy, and again, we got to shed some of the bureaucracy that we've allowed to creep into medicine.
Very good. We've also got a question from Dr. Jackson Graff, who's based in Brazil. And it's a little bit of a follow-up question to what you just described and how kind of taking a more personalized or humanized approach to care may have some increase in cost associated with it. And how do we kind of balance the need, of the costs in the short term versus getting the improved outcomes and efficiencies in the long term? Is that something that, they can confidently invest in and feel that they're going to get those, or that sometimes a hard sell depending on the organization?
It's a different sell, because in normal business, the better your product, the more people want it, and the more they're willing to pay for it. In the United States, since 65% of my payment is decided by not a patient but by the government, it's a harder sell.
Yeah.
But I think it's critical. Our competitive advantage is science, but humanized care will double down our competitive advantage, and that'll lead to more patients. That'll lead to better negotiations with our local Blue Cross. It'll lead to more patient loyalty, so you won't have as much churn as you might have. So I think the ROI is there, but it's definitely a harder sell because of the fact that 65% of my payments decided by the federal government.
Yep. Dr. Graff is right back on us. He's saying, is this an ROI that can be measured, or is it one that we just have to believe in and is rolled into everything else we do?
No. I think it is demonstrably measurable, and you can track Penn Medicine's profit margin over the last 15 so years, and you can see when we started our emphasis on patient experience. So we highly incent our managers. About 600 of our top managers, myself included, are on the same incentive plan, and patient experience is a large part of that. So trust me, I like to get paid. I make sure I'm doing everything I possibly can to provide our team the resources to provide patient experience, and that we're training our workers to do it. But the ROI is clearly there on our experience.
Excellent. Do you have any experiences or perspective or advice to share on patient and family advisory councils? What has worked for Penn? Is there any kind of rules of thumb on size or composition or that kind of thing? Or what's your take?
I think the challenge is you can't take all volunteers, because all volunteers are either going to be patients we save their lives and we can't do anything wrong, and you're going to be in an echo chamber that everything's great, or they're going to be patients who had a terrible experience and they want to make sure that we fix it. So it can't just always be volunteers. So we look at families that that one of the nurses might know, one of the doctors might know, people that have had experience with us. So I think you can't just send out a note saying who wants to come, or you're not going to get. I think you also have to use some statistical representation. So is 15 enough for a 250 bed hospital? That's plenty. Is 15 enough for a 1,000-bed hospital? Probably not, because our OB unit and our cardiac unit down at this hospital have little in common. So trying to make sure not all volunteers, representative, across a number of areas. We've begun to break down into ever smaller groups. So, we have a cancer support group and, a family support group in cancer, which is, different than cardiac and the others. So I'm repeating myself, but not all volunteers, diversity, meet on a regular basis, and give feedback. If the PFAC gives you ideas and they never hear back whether those ideas were implemented or discarded, they're going to stop giving you ideas. So you have to have that feedback communication loop.
Makes sense. Makes sense. Last question, and it kind of goes to the kind of ever-present yin and yang tension that we often have to balance. How do we ensure that our efforts to improve patient centricity doesn't end up increasing or creating an unsustainable burden on providers? And any thoughts or wisdom on how we kind of keep those two in balance?
Yeah, by recognizing that inherent tension. I'd love to say the patient's always right, but they're not. We penalize doctors if they're checking on smoking cessation and blood sugar controls. And I wrote a paper with some of my colleagues on, are there good patients or good doctors? And I could have Marcus Welby take care of my brothers. They're going to be non-compliant. I mean, it wouldn't matter. So I think first it's what we just said, acknowledge that tension and then manage it. And don't let it get too much in either direction.
Like any other enterprise, keeping the balance of the interests of the stakeholders in balance is the only way you're going to be able to sustain any progress, right?
Yeah.
Well, that's terrific. I think I got time for one more question. It's my favorite and final question. Kevin, do you have a favorite quote you can share with us? And if so, why is it your favorite?
I do. I read it every morning because it's on the bottom of an email from Penn. And if you've never been to our campus, we were founded by Benjamin Franklin. And you can't get through a function at Penn where somebody's not quoting Ben Franklin. So at the bottom of every email, the noblest question in the world is, what good may I do in it? And the parallel to that, I think, is from Albert Einstein. Try not to become a man of success, rather a man of value. So I measure myself on, am I having a positive impact on my colleagues, on our patients, on my country? Am I making a difference? Because I know how easy it is to end up on the other side of the earth. And no one's going to remember how much you made. No one's going to remember that you were the CEO, but I'm hoping somebody will walk by and say, he was a good guy. He helped me out. Or, remember when Kevin made us do that thing we didn't want to do? And now look at it. So I think measuring success by the value and impact you're having on other people is the best measure.
A wise sentiment. Kevin, we so appreciate your time and the conversation today. We're so glad that you are a part of the Humanizing Healthcare community. For our listeners who want to learn more about your work, what's the best way for them to stay connected to what's happening at Penn Medicine?
Yeah, so strongly advised, meet up with me on LinkedIn. I'm an active user, and I try to put a little personal, but mostly, what we're doing at Penn Medicine. That's probably the best way. And then once we're linked in, if you want to DM me a question or things like that, I'll always respond.
I can attest, since you and I connected, I've been seeing those updates and they keep me well informed. So that's a great suggestion. To our listeners today, thank you for joining us as well. We hope you found the discussion informative and inspiring. If you enjoyed today's discussion, please be sure to subscribe so you never miss any episodes. And be sure also to join us for our next Humanizing Healthcare discussion. We'll be talking with Dr. Victor Montori, a well-known patient care advocate and professor of medicine at Mayo Clinic. You won't want to miss it.